Dana, I also sent the PDF version. If you want to put that one up, that might be a little easier.
I feel like that's a great idea. Let me get that one up.
And while you're doing that, I'll go ahead and talk about the second slide here so that we will have enough time to talk about everything. The key takeaways from today is we're going to talk a little bit about the State Health Improvement Plan, just a brief overview about that and the work that's taking place there. We're going to talk about the demographics of Nebraska. We're going to talk about why data collection is very important and key in this work, what the social determinants of health are, information on background needs and stressors in our health system, and then how do we know we need it and what works, and then about models and opportunities, and we're going to provide some toolkits at the end of the session for everyone. Quickly, as we're talking about social determinants of health, we know that health is influenced by various factors, including, our genetics, behavior, a lot of environmental, economic, and social factors, and as we all know, medical care. And so today we're going to be talking about social determinants of health, or those social factors that influence health. And it sounds like you've all been learning about that already in the other webinars. And social determinants of health affects people and in their communities as well. So I'm going to begin the presentation talking about, as I mentioned, the State Health Improvement Plan, and talking a little bit about how it relates to social determinants of health and health equity. And I'll also share some information about our Nebraska population that highlight, and I'm going to highlight minority population as they and many underserved populations are impacted by the social determinants of health. All right, I think we can see the first slide. If you will go to the third slide, actually, that would be great. Because I talked about the takeaways. Thank you. I'm going to start, and then Allison will take over and talk a little bit about data and the important role it plays in advancing health equity. And then Janelle will dive into the social determinants of health and more information about that. And then I'll close the presentation with some things that organizations can begin doing to advance this effort. And then, like I said, we'll include resources at the end. So quickly, I'm not sure how many of you are familiar with the State Health Improvement Plan, but I will say that the NHA is a proud partner of this, and it's going to take all of us, including stakeholders, doing this work, and we're really working to promote health and well-being of Nebraska, of all Nebraskans. The vision of SHIP is working together to improve health and quality for all individuals, families, and communities across Nebraska. And this is really a collaborative, community-driven project. We had a lot of stakeholders involved at the beginning. Next slide, please. The State Health Improvement Plan does include 5 priority areas. Those include integrated health system, depression and suicide, obesity, utilization and access, and health equity. And I think one important piece, a couple important pieces here for this group is integrated health system. We're really trying to advance the integration of primary health and public health. And I think that when we're talking about social determinants of health, this is key. Not only public health, but all of the other factors that influence health, as you've been learning, that fit into the social determinants of health. So employment, housing, all those types of things. So health equity is the other one, and we're working to support organizational capacity to address health equity through systems, policy, and program efforts. So a lot of work being done to advance health equity there. Go ahead and go to the next slide. With our health equity priority, the outcome is that Nebraskans will experience health equity and decreased health disparities. So the priorities were chosen based on data-driven decision-making, and this priority was chosen because data shows that disparities exist, and that in the state we have an opportunity to decrease them by advancing efforts related to health equity. This group is working on a toolkit, and we're also working on other webinars that we're going to be presenting here in the future. One of those coming up this fall will be about implicit bias. Implicit bias is really so important as we think about the health care that we deliver to individuals, and making sure that our own personal biases don't really play a factor into that. And so we will provide that information to Dana so that everyone on this call will have information about that. But I think that'll be a really good webinar too for individuals that are interested. Go ahead and go to the next slide. Real quick about the State Health Improvement Plan, I do invite you to, if you're interested, to learn more about it, and I'll talk a little bit more at the end. All right, so quickly we'll go into Nebraska and what it looks like. So according to the US Census, and this is data from 2018, Nebraska's population was around 1.9 million. Approximately 79% of the population was white, 11% Hispanic. or Latino, 5% African American, and 2% Asian, and then 1% American Indian. We also have about 2.3% of the population that is more than one race. So this is just a picture of what the overall population looks like in Nebraska. Next slide, please. All right, I wanted to highlight here a little bit about the population change from 2010 to 2018. And we know that we're going to get a lot more data when the census is done for 2020. So it'll be interesting to see how those numbers change. But during this time, the Nebraska minority population has really been increasingly, as many of you probably know, much more rapidly than the non-Hispanic white population. And according to the US Census, during this time from 2010 to 2018, Nebraska's racial and ethnic minority population grew from about 297,000 to 376,000. So that's about a 26.7% increase. So we really need to be thinking about the populations that we serve. And that's kind of part of the theme today, is really understanding the populations that you're serving, not only within your health system or your organization, but the community as a whole. Next slide, please. I also wanted to share the map of Nebraska because I don't know how many individuals are familiar with where minorities live, but really a large portion of minorities in Nebraska live in the metropolitan areas, Lincoln and Omaha, but we also see many living in rural areas of Nebraska. And Thurston County and Colfax County, which are up in kind of the northeast part of Nebraska, they have, Thurston County has about 64% minorities. Colfax has about 50%, Dakota County about 50%. So all of those are over 50% of that population. And then Nebraska counties were made up of about 1/4 of the population, minorities made up about 1/4 of the population in Scottsbluff, Dawson, Saline, and Douglas. And you can see in the legend, the darkest blue is where minorities, we have a higher percentage of minorities in those counties. As I mentioned earlier, with the census, I think we're gonna see those colors probably change. So it'll be interesting to see that. When we do get that, we will update the information. All of this information is on our website, which I did include at the end of the presentation. So we provide a lot of data and information on our website. So this would be a great source for organizations to go to just know more about how the population changes in Nebraska. Next slide. I threw this slide in here because I wanted individuals to understand that we have a high refugee population in Nebraska. Some counties may not see that, but we really do, especially in our Omaha and Lincoln area, but in the rural part of Nebraska too. So as you can see, we have a high population from Burma, Bhutan, Iraq, Somalia, and Sudan. And actually, I'll just throw in here that our office recently we're trying to finalize this report, and it's a behavior risk factor surveillance report, and that's a report that goes out, and that's self-reported information. But we did a report with about 2,000 refugees in Nebraska to learn about their health status, because we were finding that it wasn't really represented in the larger population when we do the BRFIS. Usually. And so our office made it a priority to do this specific report. And that's something that can be shared with all of you too, to really learn about what their health looks like. One of the things we're seeing that is a challenge is language. And those of you that serve minority or other populations will understand that language is a huge challenge. Next slide, please. And then before I pass it on to Allison, I just wanted to show you, this is an excerpt from the report that we recently published from our office. And I know Janelle's gonna be talking more about social determinants of health, but I just wanted to throw this up here just to reiterate that social determinants of health are social environmental factors that influence health. And this can include education, housing, employment, poverty, access to health, and other factors. But just so you can kind of see, we included this in our report, as I mentioned, but with unemployment, African Americans were less likely to be unemployed, 11% of the population compared to whites at 4.1. Household income of American Indians were reported lowest median household income at approximately $25,000 compared to whites at $55,000. And then poverty, American Indians were at 40.5% compared to whites at 10.9. And then when you look at education, Hispanics were at 10.1. They were less likely to have more than a bachelor's degree compared to whites at approximately 30%. All of these things influence health. And so these are some of the things that, as we're thinking about the presentation and thinking about things that Allison's talking about, thinking about things that Janelle's going to be talking about, just important to realize everything that goes into the discussion around social determinants of health. All right, I will now pass it on to Allison.
Okay, I am going to talk a little bit about the data. And a disparities demographic recommendations document was developed as part of the state health improvement plan efforts that Josie was talking about. And this document provides recommendations for how to collect demographic information on a core group of 6 factors. And this information can be used to identify and describe disparities experienced by a group or community. And those 6 factors are race, ethnicity, primary language, gender, age, disability, and geographic location. And we recommend that all of these 6 factors be included in your data collection system. And whenever possible, when collecting this information, it really should be self-reported as much as possible. And the primary language questions really focus on English proficiency rather than languages spoken. And then the disability questions focus on the impact certain conditions may have on basic functioning. And geographic location, we do like to know like a street address, city, and county, so we can place that person in the correct county, correct census tract, correct local health department jurisdiction. Okay, next slide. And so in Nebraska, there's about 90 infectious diseases that are reportable to us. And almost all of them are diagnosed with a lab test. And as an infectious disease epidemiologist, our job is to identify and hopefully stop or slow down outbreaks, as well as identify and describe disparities. And giving complete demographic information is really useful to us in our efforts. And demographic information can be used to describe the health status of the community that you serve. It can be used to help prioritize and target prevention and education efforts. It helps you give services in a culturally responsive way. And barriers to accessing healthcare or other services can be identified. And it can assist in identifying clusters and outbreaks. So if you have people coming, a group of people coming into your office that have the same symptoms, and you find out they all work at the same place, or they have all been to the same concert, that kind of information is really important. And this information also helps local health departments and communities respond to outbreaks in a more timely manner. Okay, next slide. So this graph shows Nebraska's COVID-19 cases by race. So the light pink bars represent the percent of total COVID-19 cases that each race category represents. And the dark pink bars represent the share of Nebraska's population that each race category represents. And you can see that racial and ethnic minority groups are being disproportionately impacted by COVID-19. For example, Asians comprise 2.7% of Nebraska's population, but yet they comprise 5.6% of our COVID-19 cases. So they are overrepresented. Okay, next slide. And this is the same graph looking our COVID-19 cases by ethnicities. And so again, the purple bars are represent the percent of our COVID-19 cases that each race category represents, and then the pink bars are the percent of Nebraska's population that each category represents. And this shows that Hispanics and Latinos are being disproportionately impacted by COVID-19. They represent almost 42% of our cases, but represent just over 11% of our population. And this disparity is primarily being driven by inequities in social determinants of health. And Janelle is going to talk more about social determinants of health. Okay, the next slide. And this is just a little bit, when you do collect this information from patients, it might be helpful to talk to your patients about why you're collecting demographic information, what your privacy policy is, how demographic data is used, and how the information can be used by the community to benefit their community. Okay, and I am going to turn it over to Janelle.
Good afternoon, everyone. And that's a great launch pad from both Josie and Allison. So I'm going to ask each of you to think about the following slides from your own lens, to be thinking about what is being used in Nebraska, why data collection is so important, what our current populations are, both in a COVID world, and then looking at some of the surveys and data and models that were developed pre-COVID. So on this slide, think of it, if you were to pare down all of the principles and parts of social determinants of health, think at it from these simple terms. It basically means the best health for everyone. It's shifting inequality of care and health status and all of the external and internal forces that have created inequality, and shifting that paradigm over to health equity, which allows us to take population health from the community down to the one individual. And so there are various models and resources we can use to really best derive the best services and the best indicators to provide the best health equity of health for that person using the social determinants of health. Next slide, please. So another way of simply putting it, it is establishing the greatest healthcare driver is not only as physicians and as caregivers asking patients what's wrong, but what's happening. Because often what we see in a lab or in a diagnosis is simply the result of other external and internal factors that's taking place. And so by looking at it from a perspective of what's happening, applying social determinants of health, it helps us to get the broader picture of that person's true health. Next slide, please. It is also shifting healthcare, not just sick care, but treating the whole patient. So those are some simple takeaways. Next slide, please. We see it and we hear about it from a global perspective. And as with COVID, it isn't just on the other side of the world. It's not in another hemisphere. It's not in another country or another state, but it's up close and personal. So from the global to the local, it means that social determinants of health are everywhere, and everywhere they need to be established. Michael Marmont is Sir Michael Marmont, and he's actually a president of Oxford University and has served on various committee structures, including the World Health Organization. And I think he says it or captures it best. Health inequalities and the social determinants of healthcare are not a footnote to determinants of health. They are the main issue. Next slide, please. So when we think of social determinants of health, there are lots of factors, but those are both external and internal. So in this graph, you see all of the circles, pieces and parts that are the factors of determinants of health, those of which we can gauge that are visual, the social support networks, the income status, the culture, the gender, the social environments, the health and service of what's available to them, child development, personal health and practicing coping skills, the DNA, the biology and genetics of a person, the physical environments, and then the employment and education. There's also social determinants of health that are mind, body, spirit. And those are those things that are intrinsic that we often don't see, but they also manifest as what is a composition of person's health, such as What is their connection to spirituality and their ancestors? What is their connection to their country and their culture? What is their connection to their community, their family, their emotions? And those layer in on top of the first part that I talked about to really be those drivers, seen and unseen, of what a person's health is, and therefore what some of their social determinants of health might be to establish health equality. Next slide, please. So Healthy People 2020, I remember when on the SHIP committees, when we were talking about it a few years ago, 2020 seemed like such a long time ago, but here we are, and we always plan in advance. But from a Healthy People 2020, where we are now, the goals are to develop a neighborhood and build those environments and fortifications, establish economic stability, to address education disparities, social and community context, and healthcare. Next slide, please. So healthcare plays the dominant leader. Yes, there are services and organizations that are profit and nonprofit that are certainly very worthy and do tremendous value and outcomes in the community. But when we think about what a person is really lensed with in terms of how they are within community and within self, it is really within their health. And so we as healthcare leaders play a very dominant role. So the NHA does a tremendous job to provide services. So hopefully there's some great takeaways that now you can take home closer and serve the communities that you have. If it's physician clinics, the larger organizations, again, healthcare needs to see their lens, their role in each of these areas. So if you look at the top, you see that healthcare plays a role in helping patients individually see economic stability, neighborhood and physical environment, education, food, community and social context. And through the healthcare system, it is more than just healthcare provider and coverage and who the providers are, but it's also providing those linguistic skill sets and cultural competency, class standards, and quality of care that help them in their patient experience not only identify with their health, but for healthcare to help them identify where they need to be in access of food, in access of education and other types of services. So this is a great slide to be able to use to say, as healthcare providers, it's just not the structure of who we are, it's just not the payer reimbursement, it is the services that we provide to help that patient be their best patient. And then of course those health outcomes that we can help measure, which are so important, which are a part of MIPS and MACRA and quality measurements, are mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations. Next slide, please. So these are the risk factors. If you were to really break those down and say, okay, I understand these pillars, but give me a little bit more information about what does this break down to be? Well, we know that there are higher disparities in our multicultural populations, otherwise known as some of our underserved communities and populations, and even in rural health, overweight and obesity, poor diet, older age, family history and genetics, race and ethnicity. One area not generally covered is historical trauma, such as the Native American Indians and other cultural areas. There's the hidden of traumas that are generationally placed or economically placed, and that's very important context to be able to address. Natural disasters, stressful circumstances, certainly next year moving forward, COVID will be one of those that'll be identified. Behavioral choices, smoking, lack of physical activity, hypertension, high cholesterol, high glucose. Again, everyone of every culture, of every community, and every individual has a context within this, but we see greater disparities, greater opportunities to raise the bar of health equality and equity in these 13 areas. Next slide, please. So minority population's greatest health risks, as both Josie and Allison had indicated, when you do just one simple breakdown, let's take a look at where the greatest disparity is. For Latino, diabetes, 65% higher mortality and morbidity rate to diabetes. African American, they have a 40% higher predisposition and or social determinant predisposition for stroke. American Indian and Alaskan Natives have a 15% greater rate of heart disease, and Asian Americans and Pacific Islanders an 80% higher liver cancer. So that's just one map of one quick example of one designated need. And next slide, please. One of the greatest areas that I think we can all identify with in terms of what specific healthcare area is causing the greatest disruption, costs the most in national healthcare, and that's the staggering cost of diabetes in America. So imagine if we were to move the lens even closer to home and said, okay, we may not be able to fix one thing, but if we were to address one thing, what would it be? Maybe if we were to look at how diabetes is, imagine what that would mean to your own individual hospital or clinic, what that would mean certainly within a community and certainly within the nation, what that would cost in being able to do both proactive care, and then of course it always costs more for reactive care. But this is a great takeaway because this is where a huge disparity is diabetes. Next slide, please. So it's always good to be able to have a context of using surveys as part of where our information comes from. So in a 2019 Physician Foundation survey, we found that 90% of all physicians surveyed found that they have a patient base, they have at least one patient that has a social condition. They also recognize that they need to address social determinants of health and that they recognize there's a great need in food insecurity and transportation and affordable housing. What healthcare hospitals and physicians have not been able to maybe address because of the larger economic repercussions, the payer groups are certainly best positioned. And we see Aetna and Cigna and Humana and Blue Cross doing that in 22 states. And so they're coming up with some individual models of care that are completely social determinants of health driven. And so that's a great way of them being able to be champions in that area. Only 1% of all physicians who were surveyed out of the nearly 15,000 noted that they did not have a social determinant of health need. 2,000 hospitals have noted that direct patient care is from the C-suite to frontline, and that they recognize that they need to incorporate surveys and assessments to actively engage really a 360 composition of patient care needs. So it's not just one group, it's department-wide, it's mission-driven, it is culture-driven, that hospitals need to position themselves to be thinking very deliberately about social determinants of health. And then the Kaiser Foundation also found that 52% of all hospitals are currently already pursuing one social care, that physicians still need to close that gap. Medicaid expansion, which includes Nebraska, is also going to be top of mind, and that is going to create lots of wonderful opportunities to be able to finally deliberately, systematically address social determinants of health. We always know that that costs more to manage health if you don't have a plan. Hopefully this will be an extension to address more people who otherwise fell in the gaps of care to finally have their care managed at a much higher level, a much lower price point to be able to keep them healthy. And then we'll see what that volume looks like. But this is a wonderful opportunity for us to finally all be engaged as community and state. Next slide, please. Also, according to the Kaiser Foundation, we found that it costs $309 billion in losses of the economy to serve and to be able to address social determinants of health. You combine that with the cost of it is in a reactive mode to regain that care, it's $559 billion. So combined, that's nearly $1 trillion. So imagine what we could do with $1 trillion if we actually had that to manage those populations. And quite frankly, we wouldn't be experiencing levels of disparity that we are today. The American College of Physicians also has conducted studies, and they found that in 2015 there were 245,000 deaths that were attributed to low education. 176,000 to racial segregation, 162,000 to low social support, 133,000 to individual level priority, and 119,000 to income inequality. Now that's just one study, and look at those numbers. And the fact is that, you know, one person is too many, but when you do have these known numbers, it says that collectively we've been doing our homework. We know what's in front of us, and it behooves us to be able to serve those individuals. On average, there's a 15-year difference in life expectancy between advantaged and disadvantaged citizens. That means those that would be outside the mainstream of healthcare and those that are inside the healthcare mainstream. Imagine what a person could do with an extra 15 years of being healthy. And then we also need to look at things from a generational standpoint. We recognize that many of these disparities have been over a 2 to 5 year generational system, and those have created negative outcomes, higher price points over and over. Imagine now if we flipped that paradigm and actually had positive outcomes and reset those circumstances, the positive interventions we could be able to provide. Next slide, please. Also, we need to think about some other risks. So we have the patients that we're serving, but also we have a healthcare need that is also about policy and insurance rates and the pace of hospital closures for critical access hospitals. Other epidemics that were also under the lens before COVID, which is the opioid epidemic. Physician burnout and retention. Again, part of this is that it is the point of care, but then there's also what the physicians are struggling with. So we have their resiliency, their recruitment and retention, and then a lack of nurses and other specialty services. So there are shortages and disparities all around. So these are also some things that we have to be cognizant of. In a 2019 study by Kaiser Permanente, they found that half of all Americans are stressed already to meet basic needs of stable housing and adequate food and reliable transportation. Can you imagine what that would be now in a COVID world, in a survey that is 2020 moving forward? Again, in 2019, pre-COVID, 49% had difficulty paying food and rent, seeing a doctor, and getting medication. So when you have to choose putting a roof over your head or food in your mouth, oftentimes medication isn't taken. So again, by being able to provide some services, it can help that person be more stress-free and have a better opportunity for a better predictor of health. Unemployment right now, 50 million, indicates a sharp indicator for additional gaps that haven't even begun to be identified that will come into context in this now COVID world. Next slide, please. So the hospital state of mind, again, hospitals need to take a look at where are my hits and misses? Where can I really make a difference in meeting some unmet needs and social determinants of health? If you're looking at readmission rates and where your payer structures are, you're going to be looking at what can I do from a social determinant of health standard, providing better tools and resources to address heart failure and pneumonia. Also, the high ER utilizers, we've discussed asthma already, or diabetes already, but there's also plenty of opportunity with COPD, asthma, and mental health. Again, the mental health also in a COVID world is going to be driving up even more dramatically. About a third of all hospitals currently are tracking those outcomes, but all of those, that to be said, if you're measuring quality measures for any hospital programs, this is a real opportunity to get your arms wrapped around how can you be measuring that a lot more for your own reimbursements and management of care. And then 50% are already using value-based care versus fee-for-service. That's an opportunity of growth nationally. 60% are still determining health outcomes by clinical care, yet clinical care accounts for most healthcare investments. So that's another opportunity. And then CMS has completely been very ACO active and now very accountable health communities model active. And so we'll continue to see out of their innovation models over the next 5 years, additional opportunities to bridge those gaps between providers of clinical and community services. So they're very intentional from a CMS side about social determinants of health as well. Next slide, please. So again, here's a summary of opportunities. Identify those patients' needs and risks with an easy survey and assessment. Do not have more than 5 questions, easy ones that help patients help you identify where they're at in their real-time needs. Also think about things, it's all about integration. And we think about patient-centered care, we think about bringing together all those medical, clinical parts, but now we have to think externally, bringing together those collaborative parts for part of that integration team. And then also think about prevention is a great opportunity per person to be thinking about where a savings is. Why get them sick and then try to get them healthy when of course, that we are in that back seat trying to get in the driver's seat, but moving forward, recognize let's be much more planned oriented, and we can save between $3,500 and $15,000 plus per person with some general savings. And then on those high utilizers that we had identified previously, such as diabetes and asthma and mental health, at least $100,000 per patient. Next slide, please. So healthcare leadership creates all those pieces and parts that are part of the community. So think about those, this lens as we move forward into the models of care. Next slide, please. So the models that we're going to discuss briefly today were selected on best evidence of care, but they're also chosen because they have these critical components. They actually close the gaps on equity of care. They resolve mass critical need. They're evidence-based and clinical and collaborative driven. They're easy to scale, duplicate, and unique, and don't cost that much in time, resources, and dollars committed. They fit within the rural and underserved populations and needs. They drive cost savings and outcome measurements, and they create some patient accountability, which is one thing that we have not talked about enough, which payer structures are beginning to talk about in 2021, is you have your patient bill of rights, but what is that patient in turn? You can give them a prescription, but you cannot force them to do what they need to do. So a lot of things are now being modeled after, now that a patient knows what they know and they have the services available to them, what are they doing as him and her to manage their care and be accountable for it? Next slide, please. So the following opportunities were taken from the 2020 studies of the Commonwealth Fund and Deloitte and Health Leads. So they analyzed 500 hospitals across the United States. These are the ones chosen as the best practices of social determinants of health. So what these next slides are they taking a piece of social determinants of health and matching it with a best model of care. So the first one is looking at chronic disease management, and that's Geisinger's Fresh Food Pharmacy. Now, Geisinger's is across the United States, but they're predominantly in the Pennsylvania area. And already in 2016, they developed a fresh, nutritious food model that delivers the gold standard of addressing diabetes and diabetes education. So they receive basically, in addressing food insecurity, a fresh food prescription. So patient accountability is that they receive this prescription. The patients then receive 20 hours of education with healthcare coaches about diabetes and a kitchen kit that includes all the things that they need to do within their home to address their need and their family's needs to be able to have access to foods and then how to prepare those. So it has a proactive and preventive measure, and over the first 18 months, there was an 80% decrease in costs for enrollment of patients, which is also $48,000 in savings per patient per year to manage not only diabetes, but their other identified diseases. So that's pretty significant. And that's another one that's fairly easy to scale. And we could imagine almost any hospital, almost any community having access to. Next slide, please. The next one also is food security driven, but it's less disease driven and more about thriving access. So this is Northwest Permanente, so this is in the Oregon area, and they took a geofencing, geomap look of their community and then looked at those organizations within those zip codes to say, what could each of us be doing in our part to serve our communities? So if a patient can't afford access to food, the physician then notes the situation. The physician basically notes it in the EHR system, and then that physician has a clinical team member alert a food bank closest to that person's home, and then connects them before that patient leaves with where they need to go next. It might also include a waiver, a transportation or an Uber service to be able to get to that. And then they leave with food or a food coupon also. So it's called the Thrive Local Market. It currently serves 12,000 patients. It involves 7,500 community-based organizations, and in 1 year had 28,000 referrals. So you see that there's a huge need. In 2021, Kaiser hopes to include this across the nation. Next slide, please. Another one is childhood care. So avoiding adverse childhood events is Atrius Health in Massachusetts. From a pediatric standpoint, they have that 9-question pediatrics annual exam, and that helps determine where a patient's needs are, from housing to mental health. And they see that patient, and their goal is for that patient to leave with 2 connections of services. And currently they also envelop the SNAP benefits, and to date they've helped over 600 patients. Next slide, please. Travel. So we've already talked about waivers. So Essentia Health, which is also in the eastern part of the United States, uses waivers with Uber services. And they found that by tapping into Uber, they're able to establish a 97% patient appointment rate and a 98% positive patient engagement satisfaction. I mean, satisfaction scores that any of us would like. But that's a simple action, and it only costs them a few thousand a year to be able to do that. Versus what it would cost them in trying to manage that person's care, or perhaps never seeing them, period. Poverty, another social determinant of health. We'd already mentioned Geisinger Health, but in another one of their hospital systems, they have community health assistants, CHAs, which are much like community healthcare workers, but they work to improve those outcomes. And they work in that social fabric network of Meals on Wheels, churches and community service coalitions. They've been able to serve over 5,000 community patient needs, which from a broader standpoint has, as they determined, about $500,000 in savings. Interpersonal violence, childhood care, again, Children's Hospital Wisconsin addresses that. They've been doing this since the 1980s for child advocacy. They partner with the Medical College of Wisconsin, and it's called Project Ajuma, and it utilizes caseworkers to identify their needs. And the whole point of this is that teenagers are a difficult age to live in and sometimes to be with as parents, and certainly from an education standpoint. It's a tough age group, but the whole point of this home intervention project is to be able to keep those teenagers out of trouble and have access to care, reduce teenage pregnancy, reduce their violence and bullying and other types of things that are both online and in school, and to be able to keep them in the home. And so far they've been able to help 6,000 patients, which they believe since the 80s has been millions of dollars that it's helped save in the court systems. Next slide, please. So from a utility standpoint, Boston Medical Center has been able to take a look at setting up a legal site within their hospitals and their clinic centers, and their whole focus is protection letter programs. So they know, and it gets very cold in Boston in the winter, their whole focus is is to keep utilities on. And they know if they can keep utilities on, people are going to be able to keep warm. They're probably going to be able to focus some of that other stress on other things such as food. But their whole point is to focus on keeping people warm and safe. And so they've been able to help by now, it's probably well over 200 people from having their utilities shut off. But overall, their entire program in the last couple of years has helped 5,000. That 193 is just from just this last 3 months. Education, WellCare health plans. So now we actually have a healthcare plan that is working on education. And this is located in Georgia, and they're working on a GED, the General Education Development, for eligible Medicaid members. They know that if people, again, as Josie had noted in one of the earlier slides, if you can close the gap on disparity of education and give every person an advantage for baseline education, and imagine what those possibilities moving forward would be, it helps them position themselves better within the community and their health. So they've so far helped within the last year 100 families. Next slide, please. So here's some opportunities for hospitals and physicians. Get involved with ACOs. Take a look at those bundled care opportunities. Realign your mission and your vision to include very intentionally the social determinants of health. Well, also what I mentioned before is look at some of those innovation models. Look at MACRA and MIPS, whether you're in an advanced payment program, or look at some of those other types of Medicare programs that are available for a higher reimbursement rate, a better way to thread your community's health. Look at the CPC, which is a very consolidated, comprehensive primary care model, and other innovation models that CMS is continually coming out with that help those hospitals and physicians manage their physicians better. Again, we're moving out of fee-for-service and we're moving into value-based care. Also, take a look at some of those other opportunities for care in models that speak to the genetic testing tools. Again, now these are more innovation driven, but take a look at some of those that are the predictive analytics through your EHRs, those that are more genetic testing. But again, we're going to see the biggest growth moving forward in diabetes and mental health. Pharmacogenomics is that positioning, taking a blood lab of being able to better prescribe the right drug, right time, and right dosage, and then use those EHRs. We all have them. We can better position and better, I guess, manage a person's care if we look at what some of their greatest needs are. Diabetes, participate in grants, those are out there. Take a look at Fitbits and wellness solutions and thread those together within your EHRs. Those are all great opportunities, and we've probably all been doing them, but have we just connected those dots? Next slide, please. Again, the ICD-10 Z codes are a great opportunity. This is very new. That's taking all those things that we've been talking about and looking at a higher reimbursement to incentivize physicians to be able to do that. Certainly navigators and social workers continue to play a role, sharing best practices, looking at cost outcomes and ROIs are important. And if anything, COVID has produced to us that we all play a role in public health. So continue to work with those public health districts. Next slide, please. Listen to your patients. They are the best generators. They're the ones who are living the lives that you're managing. And then we've already talked about COVID funding, 340B, grants, ACOs, and other types of community funds. There will be more in, like with stimulus packages, there will be more in stimulus for grants. So take a look at those opportunities as well. Next slide, please. So these are takeaways, and again, you'll all have access to this, but take a look at where you are. This is there's some great opportunities here. Take this, use this within your strategic plan guidance. You know, take a look at where your best opportunities are for implementing the social determinants of health. take a look at where you are participating and where some of those opportunities are that you can close those gaps for best payment performance and best management of care. Next slide, please. So these are your transformation drivers. This is at the next level. This is the future stuff. Using precision medicine, pharmacogenetics, continue to look and work with your payer groups for waivers in housing and diabetic care, class standards, the eco telehealth programs. I think COVID has shown that what we've been talking about with telehealth for such a long time, telehealth works. It's better to provide care from a distance than not at all. There's also some wonderful innovative oncology models, and then really looking at enhanced depression screenings, sleep studies, and cardio testing. Use and tap into the CMMI, the CMS Innovation Center, and then rural health continues to be advancing in many grant opportunities. Next slide, please. So the last two slides are about strategies in advancing population health. These, again, you can use with those 7 takeaways as part of your strategic planning needs about increasing the health and applying those class standards, looking for opportunities to activate and be interactive with your communities and community collaborations. Next slide, please. And then each of you has an opportunity to not only be a healthcare leader, a public health leader, but a health equity leader. And you all have opportunities to continue to partner with housing and education and workforce development and city planning. Again, I know many of you are already doing it, and it's already been second nature. You just either weren't documenting it or you weren't propping it up enough. But keep up the great work and continue to not only do what you're doing, but look at opportunities to advance that. And then also use these best case models and scenarios to why invent when you can just take that's already being successfully done and take it to the next level. And to that I say, enjoy. And the next slides are Josie.
You're still
Josie,
muted.
you're on mute.
Thank you, I apologize. I just said thank you to Janelle to make this quick. We have provided just a toolkit of resources for you here. One of them that I did not include here, and as we were talking about all of this, I remembered that there's a prepare assessment tool, and it's a really good tool that provides organizations an opportunity to respond to and assess patients' assets, risks, and experiences. And it's a tool that's used at the national level. It's a national effort just to help providers collect and apply the data that they need to just really look at their patients and understand them and understand the social determinants of health. So I'm going to put those links in the chat box so individuals have access to those as well. We also provided another document for you that talks about data collection and ensuring it at all levels of your organization. So that's another tool there. Next slide, please. Just some other resources and summary of some other models that Janelle had included. Next slide. And then some more resources. We really wanted to provide you with a lot of different resources for you to be able to just take the next steps to be able to advance this work. Next slide. And then we just want to say, you know, we're all in this together. There's opportunities, as Janelle mentioned in her last slides, to join in some of this work. We have the SHIP Health Equity Priority, which we'd really love to see a lot of organizations outside of Lincoln, in the rural part of Nebraska, hospital systems, clinics, anyone interested in advancing this type of work and helping us to plan efforts around what will support efforts in Nebraska to do this type of work. I also wanted to leave that we are looking at our office specifically, and of course working within our data team at the state, is looking at opportunities to look at census level track data and social vulnerability index data to better improve data for all of us and be able to look at social determinants of health throughout Nebraska. So that is something that we're trying to do. We're going to be looking at opportunities to bring that to Nebraska. And then one final reminder is that on the resources, I put our website. This is just a vast amount of information there. We have information on health disparities. We have information, as I mentioned earlier, about demographics in Nebraska. Take a look at our website. The link I put there is to our reports page, which has a lot of that, but there's other information on our website. So we also have an annual Minority Health Conference. If you're interested, you can sign up for our listserv on our website. Just a lot of opportunities to be involved. So just want to thank you, and remember, as Janelle said, it's a lot of opportunities to partner, because it's going to really take all of us partnering to be able to have better health for everyone. Thank you, Dana. We're done. I know we don't have a time for questions, but we are open, the three of us, to answer any questions that may come up from participants.
Very good. Thank you, all three of you, for joining us today and taking time out of your day to do this presentation. And yes, so if anybody has questions, we will we can shoot those emails and connect you that way. And we are a little past 1 o'clock now. So thank you all for joining us, and we will catch up later. Thank you.
Dana, are you still on?